Hey everyone, today we're going to be doing a long lecture over vascular disorder. So this is the non-abridged version, the longer version where I'm kind of going in depth in case for some reason we have to skip my lecture, which would be so sad during cardiac, but it seems to keep happening, especially in the spring semesters. It seems like weather in Texas just does not agree with us, but also just if I talk very fast and sometimes just going back and being able to catch up with things, or if you're not in my class and you just want to have to be subjected to multiple lectures, go for it. So anyway, but this is the long version. So if you're looking for something more short, sweet, simple, to the point, there are other videos. So let's jump in here. So first, we're going to be talking about arterial disorders, and then we're also going to be talking about venous disorders. So it can be kind of confusing because a lot of times when you see the word PVD, you might think peripheral venous disease, but most of the time it's talking about peripheral vascular disease, which means it could be an arterial problem. Or an arterial problems, to remind you, are those things that it's anything involving the arteries or the blood that's taking oxygenated, the vessels that are taking oxygenated blood away from the heart and delivering them to the tissues. And then if we have venous problems, that's a problem where I'm having difficulty getting blood from that has been, dropped off that oxygenated blood. It's deoxygenated blood and getting that blood back to my heart. So kind of arterial is getting things down and venous is getting them back up to my heart. So there's a couple not mnemonics, but rhymes or things here, if these are helpful to you, that kind of tell you about ways to kind of remember arterial versus venous, because there are some differences here and you have to think about it. It all comes down to what I just brought up, is what's the purpose of arteries versus veins. And arteries bring oxygenated blood to my tissues. So if I have an arterial problem, one sec. Okay, never mind. I was reading this and I was like, wait a second. Now I have a typo on here. Never mind. I'm just losing my mind here. Okay. So anyway, so if I'm having an arterial problem, I'm having a problem getting oxygen to my tissues. So this is a perfusion problem. So this leads to some more serious symptoms. So if I am not getting blood flow from my heart to my legs, because usually the legs are the most commonly affected for PVD, then I'm going to have a problem with having decreased flow. So what does it look like when I don't have flow? Well, it looks like I have a pale color because there's less of that red oxygenated blood getting to my tissues. I am going to, have that ischemic pain. It's also known as intermittent claudication. And it's because, think of it like when you have chest pain, like in CAD, or coronary artery disease, it's because there's a lack of oxygen flow. So my tissues are saying, I'm hungry, I'm hurting. So it's an ischemic pain or a lack of oxygen pain. These patients also don't have any swelling or edema. There's a lack of flow because there is less fluid getting to them. And then the real big differentiating thing is that with arterial, they're going to have problems with their pulses. Oh, sorry, I said real quick to back up. I said that they would be pale and then also cool, because you have to think about, if I'm not getting blood flow, it's going to be colder because there's less of that warmth from the blood flow. So then when it comes to pulses, like I said, this is kind of the big differentiating thing. So I'm going to have a diminished pulse. Now, if I have an absent pulse, that's serious emergency. It's not expected ever for them to have an absent pulse, but they are going to have very diminished pulses or weak pulses, and that's because there is less flow. They also are going to be more likely if they have ulcers, or if they have, dead tissue, not dead tissue, excuse me, if they have ulcers, or if they have problems with, getting breakdown wounds, etc., that they're going to have a different kind of appearance. And the appearance is going to be a result of the fact that it's dead tissue. So anytime you think of something that's dead, they kind of like black death. And so they more likely are going to have that black eschar stuff that's on there. It's going to be like on their toes, their feet, etc. Can be around their ankles as well. But it's literally dead tissue. Like the tissues are like, hey, I'm not getting oxygen, I cannot heal. And when they get ulcers, they tend to be round and smooth versus compared to when we talk about venous, so this will all make a lot more sense. Something else that's a little different too is that in arterial problems, they do not have hair on their legs usually, and that's because in order to grow hair you have to have nutrients and oxygen, and you're not getting that in arterial. So overall I have this pale cool leg with no hair on it, no swelling, these round sores that are sometimes turning black because of the lack of perfusion, and a very, very weak pulse. And so we call it effectively, that's kind of the picture of what an arterial a leg that's having arterial problems would look like. Because it's, again, it's a problem getting blood flow to my feet. And so because I can't get blood flow to my feet, I can't get that oxygenation it needs. Then when it comes to venous problems, there's no problem getting blood flow to my feet. I have beautiful, wonderful pulses. The problem is that normally with my veins, what happens is oxygenated blood gets dropped off in my tissues, in my little toe capillaries of my toes, I'll say that. And then when it's going back into the veins and then getting pushed back to the heart, there's these valves in them, and kind of think of them like an open, closed door kind of situation. And what happens is sometimes these get incompetent where they're not closing correctly or opening correctly. And so what's happening is there's kind of a backflow of fluid into the leg. So in other words, it can't move up. So it kind of gets stuck, or it starts pooling in the bottom of the legs. And so kind of think of this like leg heart failure. And so what's happening here is there's this accumulation of fluid. So this is like the opposite of arterial. There's really strong pulses. It's really warm because there's a ton of blood just pooling around there. It's going to, they're usually going to have lots of swelling. And then when they have ulcers, a lot of times they're more in the calf area, around the legs and stuff like that, sometimes around the ankle. And they're going to look different. They're going to be irregular sores. There's none of the dead tissue because there's blood flow. There's just this accumulation of fluid. And then their pain is going to be more dull and achy because it's not an ischemic pain. It's like a heaviness almost. So effectively in venous, we have these incompetent valves or doors that are not allowing for blood flow to move back up to my heart. So I have this swelling. They're usually there's a brownish tint to the skin, swollen, like around the calf area, there's this browning area. There's usually very strong pulse present. They have these irregular sores, and just this kind of dull, achy pain that they're having. So I know that took me a while to get all of that out, but hopefully that makes sense. But that's the big difference between venous and arterial and what it looks like. So when it comes to arterial ulcers, you always have to think in that what a student told me one semester that I found really helpful, and a lot of students like to use this, is you want to think about what you want to do for arterial versus venous, is that when someone has an arterial problem, you want to think about the letter A. So like, let me see, you can put your fingers down like an A, and that you want them to dangle their legs. And you want them to dangle their legs because their problem is getting blood flow to their legs. So if I dangle my legs, and if you think that word dependent means the same thing as dangle, it means to put them hanging downward. So it's all those D's. So downward, dependent, dangle are all saying the same thing. If you keep them in that dependent position, it's going to allow for better blood flow for these patients. We want to do very good dry sterile dressings because these patients are going to be really high risk for infection, and they're not going to heal because they're not getting blood flow. They may need systemic antibiotics, lots of pain medications. Patients with arterial problems are going to have much higher risk of needing an amputation, because remember, amputation is when you don't have flow. The wounds can't heal because there's no oxygen. They're literally, tissue starts to die. So that's why they're going to be more prone to amputation. Of course, for both of these, we want good nutrition, and effectively to prevent arterial ulcers, we're going to do a lot of things like think about diabetic foot care is going to be really what's centered around for these patients. And bringing us back to what diabetic foot care included, you want to think about things like never going barefoot, moisturizing the feet well, but not between the toes, checking your feet daily, wearing good fitted socks and shoes, making sure to do good nail care. You may need to go to a podiatrist for that good nail care, avoiding temperature extremes, stuff like that. So you could go back and review that. On the other hand, this is kind of that browning I was talking about with the venous ulcers that this are regular. You can see the difference here. Look at how nice and clean and round those edges are versus this one. It's kind of all over the place. So for these patients, because their wounds are a little bit more irregular, they may need some extensive wound care or debridement. If it doesn't heal, we'll get a wound cultures and treat with antibiotics, but usually we worry a lot more about infection with arterial versus venous. They may need skin grafts, which is where we take skin from somewhere else in the body to replace the skin because they can have really bad skin damage with these. Of course, pain medicine and good nutrients. So then for venous, so remember arterial, dangle your legs. For venous, think like a V. We are going to elevate the legs. So elevation helps here. I have all this swelling in my legs and stuff cannot move back to my heart. So I need things that are going to help to get that blood from my toes all the way back to my heart. So the three things that can help with venous problems are going to be movement, compression, and elevation. So movement, what happens with movement is I have these, the muscles that surround my leg vessels serve as what we call like a muscle pump. So every time as I'm walking, it's helping to compress those vessels to push that blood in the direction it's supposed to go. Same with compression, like SCDs and stuff like that, or those sequential compression devices. Those help to push blood up to my heart. And then additionally, elevation, because again, gravity. So like if my legs are elevated above my head, it's going to help naturally to allow for that flow of fluid from my feet back to my heart. So now let's get into disease processes. That was kind of an introduction to let you know arterial versus venous, some basics, beginning stuff. So let's get into the actual disease processes. First, there's what's known as PAD. Or peripheral artery disease. And this one, I always like how the nursing.com talks about how this is BAD. So this is the bad one. This is the one you definitely don't want to get because this is the arterial problem. Anytime you hear arterial versus venous, we're always going to worry about arterial problems more because they can lead to ischemia or tissue cell death. So PAD is where it's just like in coronary artery disease, but it's in the legs. And what's happening here is there's a narrowing, and there can be a narrowing because there's plaques building up, which is going to be one of the most common reasons. Everyone has plaques, but they build up eventually to where their blood can't flow. But also it can be that there is assaults or injury or breakdown of the arteries, and this can be a result of tobacco use. This can be as a result of kidney disease, hypertension, diabetes, all those things that hurt blood vessels. It can just affect one artery or it can affect multiple of them. But the end point is that I have these blockages and blood cannot reach or flow to my extremities, which leads to ischemia or lack of oxygen. So what does this patient complain about or look like? They're going to complain about that intermittent claudication I was mentioning. And so intermittent claudication is effectively, it's intermittent pain, and it happens with exercise or exertion, and then it gets better with rest. And what's happening here is I have this plaque or this blockage, or there's something that's starting to take up space, not allowing for good blood flow through my arteries. And, it's when I'm just at rest and not doing anything, it's not bad enough where I'm actually having any symptoms. But what's happening, why it's called intermittent claudication, is that then when I am getting up, moving around, exercising, stressed out, my blood vessels constrict even further, which then leads to actual symptoms because I was already pretty blocked. But then once I start vasoconstricting, then I get completely blocked where my leg is literally like, oh my God, I have no flow. And is screaming. That's what it feels like, probably. It's like a sharp pain. That's usually what patients complain about. They may also have other signs of, we call it a decreased sensation and stuff like that, or decreased flow, like paresthesias. They can have numbness and tingling. So kind of think of it like when you sit on your leg or your foot for too long and it falls asleep. It's the same kind of thing. You're having decreased flow to that area. And so it's the same thing with this, is where they can end up with a shooting or burning pain, and they also can get those ulcers like we talked about. Their pain, that's usually early on, and then later as things get worse because the blockages and are getting worse, and the body does try to create collateral circulation or create new blood vessels to help, but these can only go so far. So what do you call it? The late symptoms are going to be that they're hurting at rest, like they're not even doing anything, exerting themselves, and they're still hurting. And it's usually worse at night. And you have to think about this is for a few reasons. First, you have to think about the position we lay. We lay flat in bed usually to sleep. And so because you don't have that dangle for arterial, you're not going to have that same ability for flow. But then also your cardiac output decreases at night. Your body kind of shunts blood to your rest and digest systems. And so you're already going to have decreased flow everywhere to those peripheral extremities. Because I mean, you don't really need it at night. Your body's not like, hey, here, let me prepare my muscles for the exercise I'm not doing. So needless to say, you're going to have less cardiac output at night when it comes to those, your extremities. Some people may have no symptoms, or they can have more atypical symptoms as well. All right. So like I mentioned, for arterial, they're going to usually have shiny skin, hairless skin. I always say this is the only way that if you never want to shave your legs again, just smoke a bunch of cigarettes, eat a bunch of fatty foods, get some PAD going on, you'll never have to shave again. You may also lose your legs, but I mean, price to pay for not having to shave your legs. I'm just saying. And that's a total joke if you don't know me. Hopefully don't take me too seriously. Like I mentioned, they'll have diminished pulses, and then they're going to usually be a pale color when they're elevated because there's that lack of flow. But once I go dependent, then I might have what's called dependent rubor, or it's going to be red because I'm getting that nice flow because of the positioning that I'm in. So how do we diagnose PAD? So we diagnose it by usually looking at a Doppler ultrasound, and this is super helpful. So like if I'm ever checking a patient's pulses and I'm like, I don't feel anything, you know, and we have little Dopplers that we can do, like that's just for the sound of it as nurses. And if I'm still not seeing, I remember this one time I was like, I'm not feeling anything. They ordered a Doppler, and when the person came, they're like, well, you're not feeling anything because there is no pulse. You know, the pulse was gone. So at least I wasn't crazy. But they can actually visualize and see how far down it goes, but they can see like you can see these are all these like accumulations of damage to these arteries here, and where things are limiting the flow. Because look how hard it would be to like get flow through some of these areas here. So it's definitely decreased. And then you add in some vasoconstriction, some exercise, it's going to get even worse. We can also do what's called angiography. And this is just like what we do when we go into the coronary arteries and CAD, except we're going into the legs, and we're going in and looking, we're seeing how blocked or stenosed are they? Are there plaques? Are there clots? What's going on? They also can do MRI and look at the blood vessels as needed. We're also going to measure pressure. So we can do what's called segmental blood pressure. So we take a blood pressure on the thigh, a blood pressure on the calf, and on the ankle. And if there's a drop in the blood pressure greater than 30 milligrams of mercury, it can be diagnostic of peripheral artery disease. And this makes sense because effectively, if I'm having decreased flow because of blockages and plaques, to my feet and stuff like that, as I take this blood pressure, you're going to see less and less pressure because there's less flow because of those blockages. There's also what's known as the ABI, or ankle brachial index. This is usually measured with a handheld Doppler. And what they do is they take the ankle systolic blood pressure and divide it by the brachial, or the upper arm here, systolic blood pressure. Now, you do not need to memorize this chart. I don't have this chart up here, but I just have it just kind of as a reference for you to kind of know. But effectively, it helps us to measure the severity of the peripheral artery disease. And so kind of seeing just how bad it is. And so it kind of gives us a better idea about flow all the way in from that, comparing from the arm to the leg. So what's the worst that could happen? So the things we worry about with these patients is that they can get this critical limb ischemia. And this is where they have like pain at rest for more than 2 weeks. We already talked about the fact that they can get wound infection and necrosis. And this is some of that black eschar stuff that, it's breaking down all the time. This is dead tissue. They get those arterial ulcers, and a lot of times they end up needing amputation. So a lot of it's about infection, tissue death, and loss of limb. So what can we do to help with perfusion? So we definitely want to start, especially if plaque, because I said plaque is one of the main causes of peripheral artery disease. We want to decrease that plaque accumulation. So we give medications like statins, which we'll talk about when we get to coronary artery disease. We'll be talking about those. There's also fibric acid derivatives, which are another cholesterol lowering medication, which again, we'll talk about when we get to coronary artery disease. We also want to make the platelets less sticky. So we want less clogging. So I always say, so there a lot of students get antiplatelets, anticoagulants, and then thrombolytics mixed up. So the way that I kind of break this down is antiplatelets are anti-clogging. So they help me so that I don't my platelets aren't sticking together and forming clogs. Because what happens is anytime I have damage to my like my vessel, the platelets, they kind of see this opening. They're like, hey, there's a cut or a tear over here. I'm going to go plug this hole. But what they do is they just form this big mesh that creates blockages and can lead to eventually complete blockages in these arteries. So we want the platelets to not stick together or be making these big, mesh things. We definitely want to be able to stop bleeding. So we don't need the strong guns. The antiplatelets are like the least strong out of all three of them. But think of antiplatelets as I'm giving these to patients who are at risk for clogging or blockages. That's usually related to plaque problems. So we can use things like aspirin and clopidogrel, which I'll talk about here next. So anyways, there's antiplatelets, anti-clogging. They help to prevent me from having any sort of cardiac events. They help prevent me from clogging, help prevent me from getting blockages. Then there's anticoagulants, which we'll talk about when we get to DVT here shortly. And anticoagulants, these help me to, I usually already have a clot. I get anticoagulants if I already have a clot, like I have a blood clot in my lung, in my leg, or if I'm really, really high risk, like I have atrial fibrillation, which is an abnormal heart rhythm, and I'm just can easily throw clots. Anticoagulants stop me from making more clots. And so this is like, antiplatelets is like, hey, I want to stop it before we even get to the fact of having a clot. Anticoagulants are like, hey, there's a clot already here, or you're so high risk that we need something a little stronger. So anticoagulants stop you from making more clots. They don't break down any clots that are already there, but they stop you from making more. And then there's thrombolytics, which we use for things like stroke or acute heart attack, acute pulmonary embolism. Sometimes we use these thrombolytics. These actually break down a clot. So we have this anti-clogging or anti-blockage, helps to make the platelets less sticky with antiplatelets. And we have anticoagulants, which stop me from making more clots if there's one already there. Then we have thrombolytics that break down clots that are there. So they help to actually lyse or cut apart or break down clots that are present. So that's kind of the differentiation there, but we'll talk more about this as we're getting into each of these individually. The other things we can do to help with perfusion is there are surgical or invasive procedures to restore blood flow as well. So let's make the platelets less sticky. So one of the meds that you're going to see given is what is known as aspirin. And so aspirin is really commonly used for patients that have cardiovascular disease. And depending on, how severe and stuff their blockages are, they're usually given like a prophylactic dose, like 81 milligrams. And this helps to prevent them from being so high risk for clogging or having these cardiac events. So some stuff to keep in mind with aspirin is it is considered an NSAID. So if you're allergic to aspirin, then usually you're allergic to all NSAIDs, or if you're allergic to NSAIDs, usually you're allergic to aspirin. Some common side effects are going to be things like bleeding, especially GI bleeding. It's really hard on the stomach, so we usually recommend you take this with food. It's already going to make it harder for you to stop bleeding because it has, the antiplatelet effect is going to put them at risk for bleeding. But it really is hard on that GI mucosa or that GI in the stomach. So definitely want to take it with food, and they need to report any bleeding they have. It can also cause stomach upset as well, so which is why you want to take it with food. At high doses or with toxicity, it can lead to tinnitus or ringing in your ears. So letting them know. So in other words, it can be ototoxic. So definitely want the patient to be aware of that. So there is enteric coated to decrease the GI symptoms, so you can recommend that. Take with a full glass of water and with food in order to decrease some of that GI upset. If you're having a procedure, you always need to let your doctor know, because a lot of times they want you to hold this because they don't want to be cutting into you if you're going to be at risk for bleeding. You need to teach them about bleeding precautions for these patients. It's not most people think aspirin, they think, oh, this is for pain, but aspirin is 9 times out of 10, especially in the hospital, given for cardiac prophylaxis or to prevent cardiac events in a patient when we give it in the hospital. So it's not for pain. It's for, it's not to decrease a headache or to help with chest pain. It's really there to help to prevent you from clogging or those plaques building up and leading to serious blockages. Aspirin's brother is known as Clopidogrel. So this has similar side effects in the bleeding in that they are higher chance for bruising, but they don't have those same GI side effects that we worry about as much with aspirin. So this is another option. And with both of these, we want to teach them about avoiding trauma and injury and teach them bleeding precautions, to make sure and to watch. They might have to hold extra pressure if they're bleeding and to report if they're having excess bleeding. And so you have to think of all the places you can bleed from. So if they're having bleeding in their gums, nosebleeds, bleeding in their urine, bleeding in their stools, any sign of internal bleeding, they definitely want to report that. Same thing about the procedures. If you're having a procedure, let your doctor know, and never stop taking this suddenly without talking to your doctor first, because if stopped suddenly, you could end up having a sudden cardiac event. Like I mentioned, there's also surgeries that can be done to help restore perfusion. So we can have what's called a FemPop or femoral popliteal bypass. And what this is kind of think of it like when they're always doing construction on 35 and, eventually you kind of learn, hey, I have to take the service road, because it's the only way around. And that's effectively what a FemPop is creating a service road because there's always traffic on one road. So I'm going to create a new route or a new way to flow. So you can kind of see it in this picture here. Effectively, they actually take a vein, believe it or not, and they take a vein from your body, because these veins, we have plenty of them that we can utilize. They take it and they go above where the blockage is, and then they bypass it all the way to the bottom and create pretty much a new vessel for blood to flow. You may be wondering, how in the world do they use a vein? So they use a vein, but it eventually gets strong and tough like an artery. So it does grow into its new role as an artery, and gets, because the inside and the out, the lumen of a vein is very different than an artery, if you didn't know. But effectively, you don't have to worry about that. That's just a nerd thing if you're like, what is she talking about? But effectively, we are bypassing where there's a blockage so that we can allow for better flow. Other options, since this is a plaque problem, is we can do similar things like we do for CAD, where we can go in and we can scrape away plaques. We open the artery and remove the plaque. It's what's called an endarterectomy. We can also go in and open the artery, remove the plaque, and then sew a patch so that it's wider and so that there's more space for that artery to be able to have good perfusion or have good flow. And they pretty much put a patch to allow for a greater stretch of that artery so that the flow is improved. And then we also, when I talked about going in and doing an angioplasty, they can go in and go into the legs. They can place stents to open things up. They can balloon open some of those arteries. They can do an atherectomy, which is removing plaque, or a cryoplasty, where they're kind of freezing off some of the areas that are causing problems so that they're not creating worsening blockages. But effectively going in and the whole goal here is to create new vessels that are going to allow for better flow, or repairing or getting rid of the problems in the vessels that are already there by opening them up more, removing the plaque, placing stents, etc. As the nurse, you definitely want to know that after a patient has the surgery, look at how long this incision is. It's from the femoral to the popliteal. And so you can see this is a very long incision. There's a couple special things you want to keep in mind. First and foremost, this patient has PAD. So they're going to have, they had problems in the past, probably with flow, making sure they were getting flow to their feet. So we want to make sure that they maintain that, because it's possible after having this that there could be an occlusion to their new blood vessel. So we want to be monitoring that pulse closely. So we're going to do our 6 P's and 1 C, watching that circulation, making sure that they have a good color, temperature, capillary refill, pulses. They're able to move it. They're not having numbness and tingling, and monitoring that pain closely. Any changes could indicate a problem, so you definitely want to be watching that very, very closely. Aggressive pain management. This is a large incision, can be very painful, and we want to tell them to avoid flexing their knee for too long or sitting in a dependent position, because it can put pressure on that incision site. We do want them up and moving as soon as possible so that we can get them feeling better. That ambulation is going to help with circulation, and it's also going to help to, oh, that's kind of cool. Like if I hold this down, it creates this. Oh, well, I thought I created something, but anyway, I'm gonna stop talking. But effectively, it helps to get circulation going, but also helps to make sure that they are decreasing their risk factors and getting back to their body adjusting to that new flow, etc. We also want to help them with activity tolerance, because let me make sure I didn't skip anything. Okay. So activity tolerance is really hard for these people, where they want to get up and get moving, but they had that intermittent claudication. So this is not, that was talking about surgery. Now I'm just talking about in general with PAD. You also have to remember that their pain is related to a lack of oxygen. So giving these patients regular pain medicine, anti-inflammatory, something like that, that's not going to be helpful to them, because they're having pain because their body is literally screaming, ouch, I don't have oxygen. So we need to give them medications that are going to vasodilate or open up their arteries so that they can actually have perfusion. So when we treat their intermittent claudication, these are a couple medications, the cilostazol and the pentoxiflin. Both of these are going to help to vasodilate to allow for better flow. We also want to encourage rest periods between activity. Walking is a great exercise for PAD. It just encouraging them to kind of take breaks, and like when they're hurting, to take a break, and then you know, they can start up again once they start feeling better. Overall, I want to teach them things that are going to help them to decrease their symptoms and improve their outcomes. So they should stop smoking. It causes horrible vasoconstriction, so bad on the blood vessels, to keep their blood glucose and blood pressure levels stable. Because the blood glucose, again, too much glucose in your arteries is going to cause breakdown of those blood vessels, and high blood pressure messes with your pipes or your blood vessels and causes them to be rigid, stiff, and narrow, and can lead to a lot of instability in your blood vessels. Weight loss can help, less pressure on the legs. Low sodium diet, so you're not retaining too much fluid and putting extra pressure on those vessels, and then managing your cholesterol through diet and medication. So a lot of times it's easy with cholesterol to be like, oh, hey, I just need to take my cholesterol meds. But diet is so key with it, because you can take meds, same with hypertension. You can take meds all the day long for your hypertension, but if you're not really sticking to the diet and the lifestyle, eventually it'll catch up with you. Then teaching them foot care. We teach them, like I was talking about earlier, the same foot care like we teach to diabetics. We treat it the same because it's a lot of the same issues. Want them to avoid injury, and then teach them how to check for perfusion, like check their capillary refill and check their pulses. So now let's get into venous problems. So these are not as serious as the arterial problems. Let me check something real quick. What we always want to keep in mind is venous problems are not as serious, but they still can cause some uncomfortable symptoms and cause some issues. So one of the venous issues we talk about is what's known as varicose veins. And these are like dilated, kind of tortuous superficial veins. So you can see them in this picture, how they kind of just show up like, you know, these veins are very prominent and very well seen on the legs. There's primary is that there's like no known cause, but we do see it more commonly in women. I'll talk about other risk factors here on the next slide. But there are secondary reasons for varicose veins, like trauma, injury, having a previous blood clot. And these, like, I mean, if you're thinking varicose veins, like what else reminds you of them? It's the same thing. They can occur like hemorrhoids. They can also be in the perineal area. You can get them in the esophagus as well, but they're very dilated, tortuous veins. So who's at risk for this? Obviously, there's a lot of risk factors here. But what's going to, and this is kind of a good description. Remember how I told you there's these valves or these doors and veins that get weak? This is a good way to show how that they're not working very well. So what happens is this valve doesn't close properly, and because of that, blood flow ends up kind of pooling in one area and puts pressure and stretches out those veins. But I have underlined here some of the most common risk factors. So being a female, you're going to be more at risk than males are for this. Being obese, because there's more pressure on the legs, it's going to make it harder for that blood to flow up. Having multiple babies, you know, a lot of times we get varicose veins just from having children, the pressure and everything like that, and through birth. So much fun and such a blessing, right? Have kids, they said. It will be fun, they said. So, and then any occupations that require prolonged sitting and standing, like nursing. So effectively being a female nurse is going to increase your risk of varicose veins. So like I mentioned before, the symptoms of this are going to be kind of that heavy aching pressure, like, you know, like kind of like just a heaviness as a whole in their legs. They can have swelling in their legs. They may feel like their legs are restless or tired. And the biggest thing we worry about with this is that because there's kind of a pooling of blood in these stretched out vessels, is they can be more at risk for blood clots. Most of the time we conservatively treat these. You know, it's not something that patients are like nonstop being like, oh, my varicose veins are killing me today. But venous disease it's also known as venous insufficiency, can lead to a lot of discomfort. So we do those things that we talked about, those 3 things that help with venous issues, which is rest, elevation, compression stockings or compression, and then of course mobility or movement, leg strengthening exercises. So this is not a problem where there's like a lack of oxygen, like PAD. So most of the time we can manage it conservatively. It's not something like, oh my goodness, if we don't fix this quick, you know, there's a serious complication about to occur. You know, mostly we just support it. A lot of people, you know, especially for women, this can be, you know, a problem with self-esteem, or they cannot feel good about themselves. And so there are cosmetic procedures to remove those, but it's just important to know that we can go in and we can maybe remove that varicose vein, but if they still have the risk factors, it can come back. So in other words, we can remove the look of it, but if the problem's still there, they're obese, they've had multiple babies, or they have a profession where they are sitting or standing for long periods of time, it can easily come back. So it's not like a cure for it. It just gets rid of the look of it. So here's kind of an example. So there's what's called sclerotherapy. This they use a chemical that destroys the varicose veins. There's laser therapy. What do you call them? There's what's called an ablation, and there's also phlebectomy, where they literally like pull it out like pulling a slug out of your leg. I've seen some videos. It's pretty disgusting, but it can improve the appearance for those that really you know, worry about the appearance of their legs. And you can see this can get to the point where it's it definitely significantly changes your appearance. So like I said, a lot of this stuff is all the stuff to help with venous issues. So avoid sitting or standing for long periods of time. Avoid wearing constrictive clothing. When I'm saying that, I'm especially talking about like stuff that's tight around the waist, because it's going to create pressure or more resistance for the legs to have to overcome to push that blood up. A walking program is great. And then things like weight loss and job modifications can help as well. So then there's also phlebitis, and this is usually referring to, you know, when we're talking about phlebitis, it can happen other places, but usually it's going to be in the hands or the arms. And it's usually a result of, it's like an inflammation of the blood vessels, because we have like an IV catheter, like a peripheral IV, and the IV irritates the blood vessels, what do you call them? And it can eventually lead to like a clot. But when we talk about phlebitis, we're just talking about inflammation. So we're going to notice for this patient that they're going to have pain, tenderness, or it's going to be warm to touch, all those signs of inflammation. You may see some redness, some swelling in that area with their phlebitis. And really all we do for this is we usually remove whatever's irritating it. So if there's an IV there, we remove it, and then we elevate it. Apply warm or moist heat and give anti-inflammatory. So a lot of people are like, wait, why are we, it's already hot. Why would you apply warm or moist heat? But that's what helps to reduce inflammation. Warmth helps to reduce that swelling, which will help with a lot of their symptoms. So don't think just because it feels hot to you that it won't feel good to have the heat on. It'll help to reduce a lot of that swelling. So that's pretty much phlebitis. And here's just some pictures of it. You can see they can get pretty irritated. And sometimes it doesn't require any treatment and they're okay, but we can definitely improve their comfort through giving them some of these things. Anyway, so now last but not least, let's talk about the other venous problem, which is venous thrombosis, VTE, also known as a blood clot. Blood clots can happen. And when we're talking here, you can get blood clots in your arteries too, but we're talking about venous blood clots or blood clots that are in a vein, and then it leads to inflammation. So VTE is just a blanket term, venous thromboembolism, for blood clots anywhere in the veins. A lot of times these are going to be in the legs, like that's what's called a DVT or deep vein thrombosis, and that's a lot of what we're going to be talking about. But you can get blood clots in many different blood vessels, so just know that, and we'll talk about some of the other ones later, like when you get a stroke, etc. And then in complex, you learn about pulmonary embolism and MI. So risk factors, there's what's in this picture here is what's known as Virchow's triad. And this is kind of the risk factors or things that can lead up to having a blood clot. And so first one is what's known as circulatory stasis. So anything that's causing pooling of blood in one place. So atrial fibrillation's abnormal rhythm we'll talk about here soon. You're gonna love it, by the way. Dysrhythmias are so much fun. So atrial fibrillation is it's a dysrhythmia where there's pooling of blood in the top of the heart. So that pooling of blood is what leads you to be at risk. Anytime blood is just stationary or sitting one place, it puts you at risk for getting clots. Immobility, so people that are doing long trips, like sitting in a car for a long time, long plane rides, they're going to be more at risk. And then if you have venous insufficiency or varicose veins, like we just talked about, you're going to be at risk. So anything where there's pooling of blood, that's the first part of Virchow's triad. The next, and it's not saying you have to have all of these, you can only have one of these and get a blood clot, but these are just showing the different things that contribute to blood clots. There's also what's known as endothelial damage or dysfunction, which is where there's that damage to the inner lining of the blood vessel, and this can be as a result of trauma or surgery. It can be as a result of plaques breaking down that inner lining, having lots of pokes, or pretty much inserting a lot of those blood vessels, inserting a lot of needles and catheters into the blood vessels. Any sort of indwelling catheter is going to put you at risk. And so I would also add here maybe like diabetes, things like that too can lead to damage to those walls. And then being in a hypercoagulable state. So anything that's going to cause you to form more clots is going to put you more at risk. So atrial fibrillation, you form clots because there's the pooling of that blood. Pregnancy, because the hormones, and also like estrogen therapy, which is going to be things like birth control. So I always tell the story of my friend, that young, healthy marathon runner that ended up getting a blood clot in her lung as a result of her birth control. So trauma and surgery can put you more at risk for making clots. If you have sepsis or certain other diseases, you're going to be more likely to have clots. And there's also genetic factors. Some people just have genetic disorders that make them more likely to form clots. But you can kind of see here, I have, there's a lot of different reasons for blood clots, but the most common ones you're going to see, atrial fibrillation is a big one. And then being immobile, which is why we have all patients in the hospital usually on prophylactic DVT prophylaxis to prevent them from getting those blood clots. So blood clots can be superficial or deep. Superficial, the skin is going to look kind of tender, painful, and red. It may be itchy to the patient, and you're going to see kind of a firm or cord-like vein, very easy to see. It's going to be very close to the skin, so it's going to be something you can visualize, whereas a patient that has a DVT or deep vein thrombosis is not something you're going to be able to see. And really, I would put your focus on the DVT because that's the one you're going to test mostly over or see most often on the NCLEX. And the things that are going to differentiate a DVT are going to be that it is, there's usually one-sided leg edema. So you're kind of looking at their legs. You could tell one is bigger than the other one, and they're also going to have redness, pain, and tenderness. They may have trouble walking on it. They may have a feeling of fullness in the area, and they can even have a fever. But that really, like, that hallmark symptom is going to be that unilateral leg edema or one-sided leg edema, like you can see down here in this picture. So we diagnose it just like with arterial disease. We look at a Doppler and we can actually see that clot. Look at this big sucker in here. It's a huge clot, blocking and decreasing flow here for this patient. We can also do CT and MRI and sometimes, but usually the Doppler is the golden standard for this because we can directly visualize and see where it is. And they can do that super quick. We also want to get labs because we want to see, like, try to look at risk factors, what's caused the patient to form this clot. So is the patient clotting? So do things like checking a PTT, INR, or platelets, which we'll talk about a lot of those labs here soon. We want to see, is the patient bleeding? Like by doing a hemoglobin and hematocrit to make sure that, a lot of times if people are pulling blood, they can also have issues with blood loss and stuff like that too. Or if, there's a lot of things like DIC and stuff like that when patients are forming clots. So we just have to keep in mind, we want to make sure that there's not bleeding going on anywhere. And then we might check for clot material. So we want to see, effectively, whenever you make a clot, there are certain things that come together to make the actual clot. And so when you're making a bunch of clots, there's kind of like, I would call it like waste products of the clot that are left over. And what that's going to present as is we can check what's called a D-dimer. And this tells us that, hey, somewhere in the body, there's clot material present, or you've been making clots somewhere in your body. It doesn't tell you where it is. It doesn't tell you how big it is. It just tells you, hey, somewhere in your body, there is clot material, so AKA you've been making some clots recently. So to kind of go deeper into these labs, let's first talk about some of the coagulation or clotting labs. And this will help us a lot as we're getting into talking about medications and anticoagulants. So for these labs, the APTT and PTT-INR, I really want you to focus not on what is normal. Like, you don't need to go in and memorize the normal APTT, the normal PTT, the normal INR. I really want you to focus on what's therapeutic. And what therapeutic means is that, when we're looking at this lab, we're looking at it to check to see if a medication is working. So we want to know if there's this range where we want to keep this medication in order for it to be working the way that we want it to. If I am not therapeutic, if I'm on the low end, the problem here, and this will make a lot more sense when I start talking about these medications. Let me back up a little bit here. So think of it this way. I have a blood clot somewhere. I'm going to start giving medications that are going to help me so I don't make more blood clots. So I'm going to be in this fine balance where I don't want to be making more clots, but I also don't want to be not able to clot at all and bleeding to death. So I need to find that happy middle range. And so effectively with these medications, we try to keep them in this therapeutic range where is if I'm below that therapeutic range, if my PTT INR is low, it's usually a sign, hey, I don't have enough medicine. I'm really a higher risk for clotting, and I don't want to be there. Then if we go too high, let's say that I'm above the therapeutic range for the PTT INR, then I'm going to be worried about bleeding, because it's all about effectively both of these, like the APTT is how many seconds, and the INR is like a ratio, but it's telling me how much time is it going to take me to form a clot. And so with the APTT INR, I want it to not, like, because normally you and me, I cut my finger, very, very quickly, I'm going to start forming I'm going to stop bleeding and I'm going to form, platelets are going to come together and form a nice little mesh for me, and I'm going to stop bleeding. That's great when I'm not high risk for clots, but if I'm really high risk for clots, then I don't want that to happen so quickly and so easily. So effectively what anticoagulants do is they help to prolong the time it takes for you to form clots and things like that. Effectively, I want it to take so many seconds or so long for me to form this clot so that I'm less likely to make clots, but I also don't want it to take forever. And I'm sitting here and I'm like, oh, am I ever going to form a clot? So, and effectively, and I'm sorry if this is confusing, but I promise I'll talk more about it. I'm trying to get for the APTT, PTT, and INR, I want it to be in this therapeutic range. These are the numbers that I want you to kind of know. And there is a difference between APTT and PTT, and hospitals use other things like heparin assays or factor XA things, but this is the one that most of the time you're going to see tested. And I know that this is not the PTT and the APTT are different, but here's the number that I want you to know. So therapeutic, when we're talking about PTT, APTT, is around 46 to 70 seconds. And that's what we want. We want them to be in that range. If it's too high, they're going to be at risk for bleeding. So if I'm above that, they have too much medicine, they're at risk for bleeding. If it's too low, they have not enough medicine, they need more, or they're going to form more clots. Then there's the INR, and the therapeutic for this is 2 to 3. When you're in a complex, you might talk about some higher ranges for certain procedures, but generally it's 2 to 3. And again, if I'm above 3, it's taken me way too long to form a clot. I'm going to be high risk for bleeding. If I'm less than 2, I am forming clots way too easily. I don't have enough medicine. I am going clotting too easily. So I'm going to move on before I just talk myself in circles, but hopefully that makes sense. So then there's the D-dimer, like I mentioned, that's the one that says, hey, somewhere in your body, you have some sort of clotting products or clotting going on here. And like, I guess you would say the abnormal for that, if it's greater than 250, it suggests that there is a blood clot somewhere in my veins. There's also the platelet count that we need to keep an eye on. If I have a high platelet count, it's usually a sign that I have too much clotting going on, or I'm going to be very high risk for clotting. If I have a bunch of platelets hanging out, they like to stick together and add to clots. If I have a low platelet count, then I'm going to be at risk for bleeding. And this is going to come into play because we're going to talk about with heparin, how it can lower your platelet count, which you're already at risk for bleeding being on heparin, and then to have less platelets, it's going to make it even worse. So a normal platelet count is 150,000 to 400,000. If it's too low, I'm going to be at risk for bleeding. If it's too high, I'm going to be higher risk for clotting. We also want to check a hemoglobin. That's our oxygen carrying capacity. We check this especially, we're not just checking it with a lot of why we're checking a hemoglobin for these patients is because they're on a medication that can cause them to bleed or have blood loss. So I need to monitor that closely to make sure they are not losing blood. It's not the DVT itself that causes them to lose blood, but through the treatment of it, they can have blood loss or bleeding. So I need to know the normals here. So if this is, I don't worry too much about it being too high. Yes, there are polycythemia vera and stuff like that. But more we're talking about here, we're going to worry about it being low, which could be a sign of anemia. So for men, the normal is 14 to 18. For women, it's 12 to 16. So I usually say if you can remember like 12 to 14, like really, if you know that low end of normal, the 12, then you should be pretty good. So yes. And then there's also what's known as hematocrit. And a lot of people, so when I say like you're going to check an H&H on your CBC, that's a hemoglobin and hematocrit. So the hemoglobin tells me how much oxygen can I carry, where the hematocrit focuses more on how much volume do I have. So if the hematocrit is low, usually it's a sign that there's volume loss or bleeding. In other words, it's a percentage, and it's usually a sign that, hey, I don't have a lot of volume, like it's low. Just like when my hemoglobin's low, I have less blood cells. If my hematocrit's low, I have less volume. It also is possible if my hematocrit is low, is that it might be because I'm diluted, like I have a lot of fluid. And so there's fluid versus particles, which I'm not going to get into, but it can be low just because I have a lot of fluid or have a lot of volume and my hematocrit's diluted. But most likely when the hematocrit's low, we worry about it being a result of them having blood loss or volume loss. When my hematocrit is high, then I worry about dehydration, if this patient is getting dry effectively, because you might think, oh, high, that's great. Like, just like we would want more, that's a good sign. But a lot of times when the hematocrit is high, it can be a sign that it's high because they're dehydrated. In other words, they have not enough fluid. So there's all these little hematocrit particles that are, outweighing the lack of fluid there. So in other words, it can be a sign that they are dehydrated or dry. So the normals here for men, 42 to 52. For women, 37 to 47. But yeah, if you can kind of remember this, remember that low end for the women, like around 37 to 45 or so is normal. That'll help you to kind of keep it in your mind, because I think it's hard with men and women to remember those differences and those ranges versus trying to think about, okay, what's the overall picture here? Now that I've confused you thoroughly, let's go to a complicated picture here that, don't worry, you don't have to know all about this and understand this. But if you're a nerd like me and think this is cool, this is the coagulation cascade. These are all the things that have to happen in order for a clot to happen. And I always imagine this is like a bunch of guys standing in a circle, high-fiving each other and saying, hey, let's make a clot. Here we go. And one person has to high-five the next one before the next action can happen. So what anticoagulants do, which are the main treatment for DVTs, is they're going to stop the process, like somewhere along that high five, that circle of guys high-fiving to create a clot. They're going to stop one of those processes, which then stops you from forming a clot. Pretty cool how they work. You don't have to know where in the coagulation cascade they stop, etc. But just know that it's pretty cool how these work. I mean, if you don't think it's cool, that's okay too. So most patients that have like people like atrial fibrillation, they're going to be on lifelong anticoagulation. Other people that have blood clots or are just really prone to clots, they may be, most people like my friend that had that PE, she wasn't on anticoagulation forever. She had like 6 months to a year or so of treatment on that. These patients are going to need a lot of education to prevent trauma and injury, what are known as bleeding precautions, which we'll talk about later. But there's a few different anticoagulants we're going to talk about. And I'm not going to name them all here because we're about to go into each of them. So let's go ahead and move on and start talking about anticoagulants. So one of the most common one used is what's known as vitamin K antagonist, also known as warfarin or Coumadin. These take 48 to 72 hours to take effect. So these aren't ones that like, hey, if I have an acute blood clot, I'm like, hey, I'm going to start them on warfarin first, because, if I start them on this, it's going to take some time to start working, and I don't want to risk them not, being at high risk for more clotting. So usually what I do first is I start them on something that's more rapid acting, like heparin, which we'll talk about next. And then once they get to therapeutic, like we talked about, like I rambled on for 10 minutes about, then we can take them off the heparin and just have them on the warfarin. So the whole point of me doing that long rambling about the labs is that you need to know that for those labs, there's the INR and then there's the PTT, that they're very specific for certain medications. So when I have a patient on warfarin, the lab that I want to monitor to see if it's working is going to be the INR. I do not care about the PTT for warfarin. It does not tell me what I need to know. The only lab, well, not the only lab, but the main lab that I want to focus on for warfarin is going to be INR. That's the one that is specific, that tells me how my warfarin is working. And there's that therapeutic range 2 to 3. If I have too much warfarin, maybe my dose is too high, or the patient took too much, or they're not responding the same way. If I'm above that 3, I'm high risk for bleeding. If I have not enough warfarin, the patient's not taking their medicine, they're not therapeutic yet, and it's less than that 2, then I'm at risk for clotting. And I want it to be in that happy middle range. There's an antidote for all of these since they cause massive bleeding. So for this one, the antidote for warfarin is going to be vitamin K, or fresh frozen plasma, or FFP, can help to reverse the warfarin. The main side effect here is going to be bleeding. So we're going to teach them bleeding precautions and make sure that they know about how to prevent injury, how to assess for bleeding, and when to report it. We want to tell them, and this is something that a lot of times people get confused because they hear, hey, you can't have any green leafy vegetables, you can't have any vitamin K. So vitamin K is a reversal agent. So obviously I don't want to be sitting over here taking a medicine, but then taking the reversal agent in my diet constantly, and just like making pretty much all the hard work that my body's doing to or this medicine's doing in my body, and just counteracting it and reversing it. But here's the thing, if your body is already used to a lot of vitamin K, like you eat very healthy, like vegetarian, green leafy diet. You don't have to drastically change your diet. If your body is used to that, it's okay. But we just, like a lot of times when people have health issues, they're like, oh man, I'm having these health problems. I need to start eating healthy. So we just don't want people to go and suddenly change their diet, suddenly increase and say, oh, I'm going to start eating all these green leafy vegetables. So if you eat a lot of them, you can keep doing it. Definitely want to monitor that closely and make sure that they're getting to therapeutic, but they can still keep doing what they're doing. But, you know, if you're not someone who eats green leafy vegetables, now is not a time to start, because it can affect and interfere and make it where the warfarin will not be therapeutic. And then of course, we don't want to take this with other drugs that cause bleeding. And so, you know, anything that's going to have anticoagulant properties or cause you to bleed. Alcohol is a hard no-no because it has its own anticoagulant properties. So then there's some other medications. There's what's known as unfractionated heparin, and you're going to see this often given. So when I'm talking about anticoagulation here, I'm talking about people that are receiving treatment for an actual blood clot. Now, you're going to see everyone in the hospital is going to usually be on, you know, some sort of subcutaneous anticoagulant, and that's for prophylaxis or to prevent them from having blood clots because they're in the hospital and they're immobile. But just know that most of what I'm talking about here is someone who's getting treated because they have an actual blood clot. Just so you know, if you're kind of confused, you're like, what is she talking about? They give it sub-Q, blah, blah, blah. You know, I'm talking about patients that have a blood clot and that need this like active treatment. So heparin can be given sub-Q or IV. It has a very short half-life, and this is a good thing. We want a short half-life, and this is why heparin is like one of the most common used in the hospital, because it can be in and out of your system really quick. And this is great because if I'm in the hospital, let's say that I have a blood clot, I'm super at risk, and I'm receiving anticoagulation, but then they need to take me to surgery tomorrow. I don't have to wait days to go to surgery or wait for this to wear off. I don't need to reverse this because it can be in and out of my system pretty quick within a few hours, which is great for patients in the hospital that we might have to do emergent procedures, etc. So most of the time when we're talking about therapeutic monitoring for this patient, we're not talking the sub-Q. Like if people are getting sub-Q shots, I am going to check labs with them. Like, you know, I'm going to check, you know, their hemoglobin, make sure that they're not bleeding. I'm going to check a platelet count. But the only time I need to actually monitor labs for a patient on heparin is if they're receiving a continuous IV infusion. So this would be if they have an acute, you know, blood clot going on. We monitor therapeutically with the APTT or PTT, or like I said, some hospitals might do the heparin assay or the factor XA. But the one that we want you to know for this class is going to be the APTT, and the therapeutic is 46 to 70. So once again, here we are. If I have too much heparin, I've given too much, my dose is too high, I'm going to be above that 70 seconds, and it's saying, hey, you're at really high risk for bleeding, you need less meds. On the opposite end of the spectrum for therapeutic, if it's less than 46 seconds, I have not enough heparin, I need more, I'm going to be high risk for clotting. So we're watching, we really want to keep it in that window. The antidote for heparin is going to be what's known as protamine sulfate. And this is going to help to reverse if needed. And the story I have about that is there was one time there was a newer nurse that was, you know, heparin is a high risk drug. So it's usually a dual nurse sign off. So she had a nurse sign off and check her heparin, everything looked good. She went to lunch, she came back, and then like her pump was beeping saying the heparin was out, and heparin usually lasts, it can last for days. It doesn't go very fast. These bags are pretty big. And so she was like, what happened? And there was a pump malfunction, an entire bag of heparin somehow infused into this patient. That was something that should have gone over a few days. So we checked the PTT and it was undetectable. It was so high. And so these things can definitely happen. So this patient had to get loaded up with so much protamine sulfate to reverse that. But that's why we have reversal agents, because these things can happen. So the big side effects are bleeding. Something that's different is that heparin has other side effects too, where even though it has this convenience, it has a short half-life, it's used very often, there are some things we need to look out for. Long-term, it's not the best for use because it can lead to bone breakdown or osteoporosis. And then they also can have what's called heparin-induced thrombocytopenia. So this is like an autoimmune reaction where your body's like, hey, this is not mine. What do you call it? I don't want this in my body. So it starts breaking it down, breaking down your platelets. So effectively what's happening is that the heparin causes you to break down your platelets to have has a very low platelet count. So that's why with these patients, I talked about with warfarin, go back it up real quick. I talked about with warfarin, we're going to monitor the INR. Also going to maybe check my hemoglobin, see what's going on with that. Make sure that they're not having a decrease in that. So those are the two that I mainly monitor for warfarin. For heparin, I'm going to need to monitor the platelet count because they have this risk for heparin-induced thrombocytopenia, as well as the hemoglobin, because I'm going to be worried about them having bleeding or this reaction. So I check it every day and kind of see it. And if I'm seeing huge drops in my platelet count, I definitely want to let my doctor know. And then remember with the PTT, we're only really checking that on patients that are on that continuous IV infusion. But effectively, getting back to the heparin-induced thrombocytopenia, with this, we stop the heparin and we start a non-heparin anticoagulant. We usually use argatroban or other medications intravenously if we need a different choice, because this one is not safe. So now let's talk about heparin's sweet cousin, known as low molecular weight heparin, also known as enoxaparin or Lovenox. You've probably given this or seen this in the hospital. And so this is heparin's cool cousin that actually has great benefit in that there is less chance of you getting that heparin-induced thrombocytopenia, less chance of the osteoporosis, and it has a longer half-life. So this is great for people that maybe, hey, we're not taking them to surgery, we're not, going anywhere with them. We just need that anticoagulation protection. And so we can give them that longer half-life. So we don't have to poke them as much. With the heparin shots, like the sub-Q, if I'm giving sub-Q heparin, I have to give those like 3 times a day. With the Lovenox, sometimes it's 1 time a day. So less pokes, which is always nice. The biggest benefit of the low molecular weight heparin is we don't have to monitor anything. There's no APTT that needs to be monitored to make sure that it's safe. So with warfarin, that's one of the downsides. It's an oral medication, and they have to, like, when they go home on that, they have to go and get regular checks to see what are their blood levels, how are they doing, is it safe? With the heparin, we have to draw their blood regularly if they're on that continuous infusion to see if they're at therapeutic. But with low molecular weight heparin, we don't have to monitor to see if it's therapeutic. Like the dosing is pretty straightforward, or if they're getting this dose, they should be protected. The one thing we will monitor is the platelets. We're still going to monitor the platelets because even though it's less likely, there's still a chance they could have the heparin-induced thrombocytopenia. This is a heparin product. So we want to make sure that that we're checking a platelet count daily, and maybe also checking that hemoglobin, of course, making sure they're not bleeding. Since it is a heparin product, it also has this same antidote. So we're going to use that protamine sulfate as well. There's also new age or new oral anticoagulant. Here's just a couple of them. So there's the dabigatran or the rivaroxaban, apixaban, stuff like that. And so here's just some mnemonics for you here. So the great thing, these are oral. And so they no sticks and stuff like that, which people love. They can go home on these. And the great benefits is there's no monitoring. Again, no therapeutic monitoring. I mean, again, we might watch some of those other little things like checking hemoglobin and stuff occasionally, but they don't need to go in and have regular labs drawn. They don't need to go in and have like a therapeutic level drawn at any point, because there is no therapeutic to check for most of these. The disadvantage is that it's more expensive, and so these do cost more money, and it can be a little bit difficult for patients sometimes to afford this. They have a lot of like vouchers and stuff, but it only lasts you for so long. And like I said, a lot of people are on these medications for the rest of their lives. We are seeing more people on these days because it is allowing for less like long-term monitoring, where they don't have to go to the doctor all the time, like with warfarin, where they have to have those INR checks all the time. So how do I prevent blood clots, or what education do I need to provide? Overall in the hospital, we prevent blood clots through using those compression devices like sequential compression devices, compression stockings, foot pumps. We also put them on that VTE prophylaxis, like I talked about, that Lovenox or heparin shots while they're in the hospital to prevent them, since they're mostly more immobile than they probably normally are. We're going to encourage, of course, movement if they are allowed to move. I'm going to encourage leg exercises, which can help to decrease the stasis of their blood, which would put them at higher risk for blood clots. Part of my role is also to teach them how to prevent complications of their drug therapy, whether they have a clot or they don't have a clot. I do not, what do you call it? If they're on anticoagulation, they're going to be at risk for bleeding. So I need to teach them how to prevent trauma and injury, and I need to monitor those blood levels or any signs of bleeding to make sure that they are safe. If serious bleeding does occur, I'm going to give the reversal agent, which, it sounds great. Hey, I gave too much heparin here. I'm going to just give the reversal. But you have to consider, if the anticoagulant is reversed, what are we worried about? Well, we're going to be worried about clotting, because now I'm going to be super high risk for clotting. So I definitely need to help with that. And the other thing I don't have listed here, but that always helps if, to thin out blood a little bit, is good hydration. If it's appropriate for the patient, we always want to do good hydration for them, for sure. So then patient teaching for anticoagulate. Oh, well, I have it right here. I thought, for some reason, I was like, how do I not have that on my PowerPoint? But I guess I do. So hydration helps to prevent, kind of works synergistically with anticoagulation. So that I have a decreased risk for having that thick blood that can lead the blood to clot. I want to these are the general bleeding precautions that we're talking about now. I want to teach the patient to avoid trauma. So no contact sports, high risk activities. In the older adult, I'm going to be worried about fall prevention. So teaching them about environmental hazards so they don't trip and fall, because falls like bleeding from anticoagulant as a result of a fall is really common in older patients. And they actually look at it in some older patients, even if they have a blood clot, et cetera. Sometimes they look at, hey, sending them home on an anticoagulant, and they have such a high chance of falling, especially if they're confused or have dementia. Sometimes they decide, hey, as much as we don't want them to have a blood clot, they're more likely to fall and bleed to death than they are to get the blood clot. So, it's definitely a risk versus benefit. We want to have them avoid IM injections. The intramuscular area is very vascular. So we want to avoid that, giving shots in that area, because they're high risk for bleeding. If bleeding does occur, they should hold pressure for 10 to 15 minutes over the site. They should avoid taking things that are going to increase their, or I should say, decrease their coagulation or make them more likely to bleed, like aspirin and NSAIDs are antiplatelets, and I'm going to make that worse. Fish oil, and there's a variety of other meds that can interact and cause there to be worse bleeding. Like I talked about, limiting alcohol, because alcohol is a natural anticoagulant and can lead to a lot of problems itself. And then last but not least, I said they always need to know about what are the signs and symptoms of bleeding. What does bleeding look like? Where should I look for bleeding? So black tarry stools, any bleeding in their gums. We want to use a soft bristled toothbrush to prevent them from having that breakdown on their gums. Blood in their urine or their sputum. What do you call it for sure? Just definitely, if there's any red or brown tinge to it, they should report that. Any sort of coffee ground or bloody vomit, they should report that too. And then if they start feeling lightheaded, dizzy, or any signs like where they're having some orthostasis, they may want to report that, because they could be having internal bleeding or a change to their blood pressure. So that is vascular disorders. I know that was long and very painful, but hopefully you enjoyed it somewhat, or if nothing else, hopefully it was somewhat helpful to you on your fun journey in nursing school. See you next time.